Good morning, everybody. Hopefully, I will try and make it as interesting as possible and give you a few take-home messages today. And at the end of the day, I hope to show you and us the value that we create. So, laboratory medicine, the times they're changing. Around 95% of clinical pathways rely on patients having access to efficient, timely and cost-effective pathology laboratory medicine services. So we're probably the one service, along with the GP service, that touches patients and individuals' lives from cradle to grave. So the services we provide, the screening, the monitoring, the diagnostics, touch people's lives all the way through from prenatal to post-mortem. Every single step of the way. So we have huge value, we've a lot to give, and it's very, very important to get it right and to demonstrate that. So whether it's prenatal screening, it's post-mortem testing, through our middle years, it's important that we demonstrate that laboratory medicine has that impact. So laboratory medicine, and we're talking about it all the last 2 days, and it's delightful to be here. We're hugely influenced and impacted by the environment in which we practice. Because we're a service provider, we're seen as that, where the influences outside have huge tellings on our budgets and whatever. So in Ireland, we have our national agendas, we have our policies, we have so many policies out there. And the policies change and the agendas change depending on the month and the year. At the moment, our policies look after waiting lists, because waiting lists are the big thing. So no matter what we do, it's to try and get the waiting lists down. Next month, it'll be trolleys in the ED, the number of trolleys. Coming up to Christmas, it'll be the flu virus. So everything is centred around what's happening now, reactive medicine. So because we're a service provider, we're seen as being influenced by that, and our budgets are influenced by that as well. So we've lots of policies. We have our HSC national plan. We've just recently had Sloan Care. We've had capacity review, all having different and demonstrating different roles for laboratories in it. They recently published Sloan Care. It moves laboratory medicine into the community. So a huge shift from what was seen as acute care, primary and tertiary care. Now we're looking at moving it into the community. So laboratory medicine has to follow that, and the times they are changing. We're governed by guidelines. We've lots of them, from cancer strategies to maternity strategies to point of care to cervical screening. All govern what we do and how we practice and what we plan in our budgets, in our strategies every single year, and sometimes they're reactive. You've all had your laboratory reform and reviews. We've had so many laboratory modernisation reviews. They've been the same story throughout the world. So what is it doing? It's trying to reform us. So it'll either kill us or cure us, and I'm hoping it will somehow cure us. And of course, political factors have a huge influence on what happens us in laboratory medicine. So any scandals, any controversies, we have that whole reactive. Our priorities have changed in the last 6 months to looking at cervical screening. And patients have a huge influence on that. So we had a recent controversy in Ireland. For anybody that didn't know about it, we've had our blood scandals. And they've all changed us and probably made us better at our laboratory medicine. Not at the time, you don't think it, because we're directly influenced by it. And in general, laboratory medicine does get the bad news stories. We don't necessarily have, be involved in the good news stories, and that's the unfortunate thing. And I think we need to change that. We're directly and greatly influenced by trends in medicine. And we can use these as challenges and opportunities. As we all know, because we have an ageing population, we have technological advances, lots of different, you know, all the ones in red down there, evidence-based medicine. These trends in medicine directly influence laboratory medicine, and they're challenges, but they're also opportunities. There are opportunities to change. Our demographics are constantly changing. There are opportunities to change what we do and how we do it. 30 years ago, we wouldn't have had a sickle screening service in Ireland, but now it's an essential part of our service. So we have to change with our demographics and to know that and to be very aware of that. There are lots of challenges, and I'd like to call them opportunities rather than challenges, facing laboratory medicine. Whether it's rapidly evolving test and measurement technologies, rapidly increasing laboratory test menus, of course big data, how do we manage all that information that we have, increasing costs for instrumentation and reagents, and then growing test utilisation but decreasing reimbursement. There's a and because of all these increases, there's a huge variation in pathology testing, particularly in primary care. And challenges we don't think of, the regulatory landscape, because we have all these new ideas and innovations coming in, it has huge implications for the accreditation of laboratories, for the staff themselves, for staffing laboratories, because worldwide we're having staff shortages and skill shortages. So these innovations and trends have huge implications. We need that skill mix and that expertise to deal with those trends. So as Gunny Highways said, you adapt, you overcome, and you improvise. And these challenges are opportunities, and I think that's what we need to do. So laboratory medicine. So we've all heard the statement 70% of, it influences 70 to 80% of clinical decisions or healthcare decisions. But that is for approximately 2% of the budget. Now, anybody out there thinking, that's a huge zone of influence, and we don't necessarily use it. We bandy around the 70 to 80% that it influences healthcare decisions, but for a 2% input, it's a huge zone of influence. So we have big impact for very, very little cost. But what do our users think? Do they know that? They actually don't care. They don't know what our costs are, and it's irrelevant to them. Maybe I'd like to think the reason for it is, if I want to get, say, my hair done or something like that, I'll go and pay whatever it is because I'll get good quality. So I don't necessarily, my husband would kill me, but anyhow, I don't necessarily say I care about the cost. I do want good value, but if the quality is there, I'm willing to pay for that. So I'm hoping that's what they think, but not necessarily. So what do we need to do to tell people about that 70% of decision making? We need to create an effect and make connections and tell people how valuable we are. Because currently what we're seeing is as a commodity. The first thing that happens if there are any pay cuts or any budget cuts, we're seen as a service, a commodity, and we're cut straight away. So we need to say, actually, for 2% of your budget, we're doing very, very well, and we need to have that splatter effect, go out, create the effect, make the connections, and tell people the value that we do. That we're not just giving out a lab report, as Eric said yesterday. We need to make it matter and make it meaningful. So how can we do that? We can have loads of meaningful relationships with people. We need to do that. We, as scientists, as pathologists, we need to form those meaningful relationships. Rather than being inside in the laboratory, we need to get out there and ask people what they want. So a relationship is always a two-way thing. So you ask them, what do they want? Our clinical colleagues, do they want their test results at 8 o'clock in the morning? What do they want from us? What way do they want the report? What way does it suit them? We need to be involved in education. We need to bring in our students. We need to be involved in the academic curricula. We need to be involved in research, clinical trials. We saw the benefits of it yesterday. And enterprise. We need to be a two-way relationship with our enterprise. Just like Cerdan this weekend, they're getting lots of ideas, and I hope we're giving those. And it's a two-way thing. They ask us, we ask them. And with the effect, the laboratory medicine is central to what's happening. We're constantly learning, and they're constantly feeding back to us. And they can come and visit us too. So this is a fantastic initiative that was started in the UK called Harvey's Gang, where the kids that are being treated in the hospitals come down to the laboratory and see what's actually happening. And I just think it's a fantastic initiative. You know, involve the patients, see what's actually happening. Let them be in their own care pathway and show them what's actually happening. And they will know what pathology is about. And it's a two-way relationship. Then we can find out what those kids really want, what scares them about being in hospital. And this has reaped huge rewards. We see ourselves as the central role in laboratory, in the hospital. We see ourselves as having a central role, as touching all the other disciplines, as being very, very important. But do others see us as being that central role? We could do so much more to create that central role. Like, what would other disciplines put in there in the centre that touches every discipline? They might actually put in the canteen is very important to them all. Finance is very important to them. Procurement, not necessarily laboratory medicine. But what we want to do is create that value that they will see us as having a central role. They cannot do without us. They need us, and we need them. So we're working in partnership rather than a service provider, rather than a commodity, which has huge implications for our budgets. So what we need to do is move from being a service provider to a value driver. And as you know, there's huge threats when you're a service provider, because if you stay as you are, when the budget is cut, as I said earlier, we're the first thing to go. And test services are the first things to be cut. So on the table, we're seen as a commodity. So we need to move from that service provider to being a value driver. It's an opportunity for us. So if we're at the table as a value driver, we can tell them that and in partnership, that we can provide services beyond test reports for downstream value. It's an opportunity for us. We want to say we're not just handing out numbers. We're not just handing out that report and on the 5th page we give the diagnosis. We want to be there at the beginning, giving the diagnosis and having an influence and being partners in our patients' treatments. What is laboratory medicine all about? Well, up to now, we've been so concentrated on quality and cost effectiveness, and we've done these exceptionally well. Our accreditation systems are fantastic. Our hospitals look at them and our other providers and they say, well done. You know, we want to emulate that. But we've done that really well and we need to continue to do it. But as I said, we need to move to now clinical effectiveness, because in order to do that, or in order to be partners in medical care and in patients' care and in the individual's care throughout their lives, we need to be clinically effective. Dr. Arms said yesterday, there's lots of technology out there and it's absolutely fantastic. But when you choose a test, you need to make sure that it adds to the patient and it adds to their pathway. So we can have lots of innovations, but it needs to be clinically effective. So just because it's a quality test and it's cost effective, it needs to contribute, and we need to be there to tell how wonderful this test is and how effective it is, and it's a two-way partnership. So why do we need to adopt that value-driven approach? When we need to, as I said, we have the expertise, we need to use that to develop better outcomes. We need to support the doctors. They have been given a maze of information. We're giving them data overload at this stage. We need to support them in making better decisions for their patients. We need to give them, and what this will do is help them make faster decision making. We need to claim a place at the centre of clinical care despite the perceived ancillary nature of our offerings. So we need to be there. We need to escape that current path of commoditisation and ongoing budget cuts that are affecting us hugely. And we need to build new positions for ourselves in patient pathways. So what does the future look like? What's my vision for the future? Well, as I said, the application of value-driven offerings as opposed to a service provider. We talked a lot yesterday about the different laboratory information systems and what's actually out there. We need to use those and use them together with our users and to provide that service, so that when they order the test or when they utilise our services, they know what they're actually doing and they know they're well informed, and nobody can inform them better than us. And this is a huge unmet need, and this contributes to the huge increase in tests and the unwarranted tests. There's about 40% unwarranted testing done. We need to help them with test reporting. So as I said yesterday, Eric gave very good examples. Explain the report, tell them what's happening. When I go back now, I'm going to look at our haematology reports, because what we do is we give them lots of numbers and then we give the diagnosis at the end. I think we're going to look at, maybe I'll suggest it, that we give the diagnosis at the beginning and tell them and make it easier rather than that whole scientific kind of lingo, that we need to put it in layman's language. We need to be diagnostic supports, and there are lots of ideas out there, diagnostic support teams, where you go and you meet the different users of them and support them and tell them what they need. So either on a one-to-one basis or through computer-aided technology. There are other ideas, being there for condition and population management, and of course the use of digital pathology to further the services and add value. And we've heard all the advantages of those over the last 2 days. So what will the future look like? Word map. Of course we're going to have laboratory rationalisation and harmonisation, because we need to do that to look at our demand management and, as I mentioned before, looking at our tests, the laboratory tests as a formulary. What I like to think about the future is 3 I's. So what we're doing is we're investing in the 3 I's. These are my principles. I'm just trying to make it a little bit easier. To invest in individuals, which are very, very important, the ideas or the innovations, and the infrastructure. So we have lots of innovations out there. P4 medicine, but always keeping the patient at the centre of it all. The modern medicine for modern pathology for modern medicine, with all the genomics that's going on. Companion diagnostics and personalised medicine. Technology on site of service. We're moving from the laboratory to the patient. Point of care testing, specialist clinic testing, mobile testing, high street testing. These are all happening with opportunities, but also challenges in keeping it right and making it cost effective. So everything we do, clinically effective along with being cost effective. Maybe soon we'll be moving to the lab in the home, or telelabs, or testing in the operating theatre. This is a very nice concept where you've mass spec in the operating theatre and they're diagnosing tumours at the site rather than doing frozen sections. Maybe the future. Infrastructure. What is happening now and what will happen in the future? Well, we have and we're going to have large super-regional laboratories and outsourcing and cost containment and the McDonaldization principles. So I suppose with accreditation you get that, where everything is SOP driven and there isn't that thinking outside the box. And it does create problems, but it also has opportunities because it allows us to standardise and harmonise our practices and have best practice. So we're all used to laboratories having 4 or 5, the usual disciplines, but now there's a huge reorganisation of the disciplines into blood sciences. So huge changes for staff and infrastructure. So people that were once in haematology, now maybe haematology and biochemistry are all together. What effects does that have on the people? Like we were talking about it last night, they may work together, but they don't necessarily go to coffee together. Does it work? You know, there's still that whole divide, even though departments have moved to blood sciences. And that has huge challenges and impacts on the service we provide. If we have a service that is merged, but the people inside of it aren't actually merged. So, and maybe we will have departments of point of care, lab on a chip, biobanking, we have all those, the lab on the home, that we will have disciplines that look after those specifically. And our next speaker will talk about integrated diagnostics, and maybe that is the way we're moving to the future, that we will have break down those barriers that we've had, the radiology, the pathology. Maybe we're going to have integrated medicine. From an automation point of view, pre-analytical stage, we're moving towards automating it all. What are the advantages of it? It moves out the human error, the delays, and it also allows us to demand manage. Automation, lots of it in the future, and lots of it that needs to be absolutely fantastic innovations out there, but at the end of it always needs to be validated, accredited, and add value to the system. Digital pathology, again, another huge cog in that wheel, very, very important in bringing the information to the user and to the patient in a way that's understandable and faster and quicker. And in the post-analytical stage, so we have that link between digital pathology maybe and the post-analytical stage where you have that whole laboratory reporting, and that the laboratory reporting goes into electronic report into the electronic patient service. So a full, from beginning to end, electronic reporting system. But as I've said before, we can have all these advances and measurements, and we can have all these innovations, but at the end of it all, and that's what very much came out in our recent controversy with Survival Check, at the end of it all, you can have all these wonderful things, but the patient wants their result to be a quality result at the end of the day. It needs to be accurate, reliable, and timely. So, you know, there's no point in doing fantastic innovations if you don't have those as the backbone. We need to ensure that our diagnostic tests that we provide are, that we can trust them, that they're meaningful, and that they're helpful, despite all the innovations. The individuals, I think this is probably the most important part in it, because without the individuals, we can't do that. So we can have all the new innovations and all the proteomics and metabolomics, etc. But we have to think, how is this going to impact on skills training and our operational requirements? If I want to bring in a new service in the morning, I can't necessarily do that because I have to look at my staffing resources. I have to look at my expertise. And any new innovation out there, we constantly have to think about that. What expertise have we? Can we do that on site? Can we outsource it? Do we need to send it to a reference lab? So anything that's required from our clinicians, we need to look at that. And individuals are very, very important in that pathway, the skills that they have. And we need to support the individuals in the laboratory, but also the individuals that use our services. So it's not just about us in the laboratory, because I said we're a partnership. We need to support those individuals out there that are using it. We need to support our patients. We need to educate them. Education is the big thing. So if we have lots of wonderful tests out there, we can't just go with something like that without educating our users, educating our people that we have in our laboratories, and educating our patients. This is a nice paper, what it was, doctors and the huge number of genetic tests that are being frequently ordered, and the confidence levels they had in interpreting them. And primary care practitioners, they found that only in 46% of the time would they have been able to interpret those tests. So that's a huge, probably failing on us as laboratory service. I hate to say providers, but we're the laboratory medicine. So we need to keep pace with change. New technologies are new opportunities, but they also need new skills and upskilling of our staff, upskilling of our users, upskilling of our patients. And we need to do that through our colleges, when our people are going through college, when they come out. So we have lots of people in our laboratories at the moment that there's a new kind of innovation age, and they're not necessarily familiar with that. We had it with computers a few years ago, that people were afraid to use them because they were just, it was new to them. So we need to get the early adapters. So we need to put these new innovations and work with the colleges and work with academia in that. The academic programs. For continuing education, we need to be aware of it. And of course, we need to be able to accredit our staff and credential them. I talked about diagnostic supports. It is so important for us when we introduce new tests that we provide that education and knowledge to our users that are using it. Tell them what we're doing and tell them how to interpret it. And so our lab the lab will be then viewed as a value partner as opposed to a service provider. So there are lots of potential new roles in that, and we need to be aware of that, and we need to be cognizant of it and jump on those opportunities. Diagnostic management teams. Maybe we need primary care liaison scientists or doctors, where you would have somebody that liaises with primary care or external users of the system and tell them what our pathology tests are about. So I like this little acronym, and it's you probably have seen it in different journals, and it means adding value to future laboratory medicine, and through the acronym of science. So we need to, at every step of our process, as I have talked to you today, at the standardization and the harmonization, we need to add value. Clinical effectiveness, innovation, evidence-based practice, novel applications, cost effectiveness, and education of others. We need to be cognizant of all these paths in that pathway when we are bringing in new tests and new diagnostics. So what will the future look like? Us as partners in patient care, laboratory medicine as a value driver, and we will be showing our clinical effectiveness at the forefront. And of course, ongoing investment in laboratory medicine is crucial, but we need to show that value to increase that 2% to even 3%. It would make a huge difference, and see what we could do with that 3%. So I think the future is bright, but we need to be also cautious. We need to bring clinical effectiveness and value for the patient, and that to be at the forefront of everything that we do. and to remember that we have a patient at the end of the day. So thank you very much.